So I want to take a few minutes to talk about risk stratification. As we talked about before, when we started this whole process, someone said, we need you to risk stratify your patients, and we said, what are you talking about? And now, in hindsight, I have a little more understanding of what that means. Is everything okay? And so just a story. Yesterday, I was on a conference call with our corporate office in Nashville. And so our corporate offices in Nashville, they own 31 hospitals, they employ umpteen thousand patients. And we were talking about managing our own population of employees. And Chuck, I'm getting a lot of feedback here. Maybe I need to adjust my hearing aid, I don't know.
Battery's dead.
So I was talking to our corporate office, and they were talking about how we can manage our employees in terms of a population. You know, we are completely responsible for the cost of our employees' health care. And the question that they asked was, can Utica Park Clinic risk stratify? And it was an attorney, and it was an administrator. And so they asked me, they said, Dr. Gallus, can Utica Park Clinic risk stratify? And I said, well, what do you want us to risk stratify for? And there was a pause for about 10 seconds, and they said, we don't know if we understand what question you're asking. I said, that's because you don't understand what risk stratification is. So we're going to talk a little bit about that and how it applies to what we do day in and day out, especially managing high-risk populations of patients. And so I want to talk a little bit about models. I want to talk a little bit about how we use models to manage registries. And how we build strategies around what we would consider our highest risk patient population. So, what do you all think is the best risk stratification tool? Does anyone have any thoughts about what you consider the best risk stratification tool? Who uses LACE? Who uses AAFP? Who uses in their own internal model? I know that the Blue Crosses of the world, they have their own proprietary models, right? And that tells them everything they need to know about a patient. They don't need any more information beyond that, right?
Wrong. Coming to them.
So here's what I think the best risk stratification tool is. It's what we see in our offices. Now I will say this. When we're talking about managing populations of patients, that eyeball doesn't work so good when we don't see them, right? But I think when we designed our models initially, we wanted a model that was not as much data-driven as much as it was eyeball-driven. And so we asked the providers, what's the likelihood that you think this patient might not be here a year from now? That's a really good indicator that that patient is a high-risk patient. And so that's when we start talking about advanced care planning. You know, if we have people who are in the top 10% of our highest risk that don't have advanced care planning documents, we need to fix that problem pretty quickly because they're not having the conversations they should be having. So when we talk about stratification, what are we talking about? What are we stratifying for? This is a long list, right? We have stratification for disease states, so we have a heart failure stratification tool, a COPD stratification tool. In readmissions, we use LACE Plus. We use global cost. That's the type of stuff that we do with our HCC scoring when we do our coding, and that's what Medicare likes to use. How accurate are any of these models? Not very accurate. And so I think that's why you have to really pair what individuals see with what the tools tell you. I can say this: we have some models looking at an example. We have the Million Hearts program, which is a CMS initiative similar to CPC. We don't participate in that, but one of our partner groups does, and they have their cardiovascular risk tool that calculates risk, and they segregate people out who have a risk of over 30%. 30% is really, really high. But that is one of the models they use, and so we're looking at all these different tools. I think the message here is really this: that what we have to do is look at the population of patients that we're segregating, and then find the tool that helps identify those patients with the highest risk. And so I think one thing I would like you to walk away with is this, is that when you're risk stratifying, ask the question, what are we risk stratifying for? What population and what are we risk stratifying for? Because you can stratify for a heart attack, for stroke, you can stratify for admissions. None of the tools is perfect, but you have to ask the question, what is it you really want to accomplish with the tool? And then figure out how to embed that tool into your processes. So what are we trying to do ultimately? Well, one would be better outcomes for the same cost. So if you can improve quality and it doesn't cost you anymore, good for you, you've done something right. How about the same outcomes at a lower cost? That's a little tougher, but if you can control cost and not hurt outcomes, that's still a good thing. And actually, better outcomes for a lower cost. And so when we're stratifying patient populations, what are we trying to do? We're trying to do one of those three things ultimately. And I think you have to think about that in those terms. So we talk about all these different models, and I don't want to go into a lot of details, only to say, you know, you have a job, and that's one to educate your physicians and your providers about some of these different tools and how they can use them. I think, you know, for example, our FEV1 for our COPD patients, that's a great way to stratify, right? If a person's got an FEV1 of under a liter, they have a higher risk for admission to the hospital. We have A1C stratification. You know, if their A1C is over 9, we call them high risk. Well, we're probably not going to change their admission rate over a year's time with that, but we are going to identify people who need additional education, resources, and we're looking at long-term stratification at that point in time. You know, maybe we can impact amputation, eye disease, kidney disease by selecting that population. So again, looking at what tools you want to use and thinking about pools of patients when you're risk stratifying. So the other thing is the HCC scoring. So I don't know how much education you all do. We've spent a lot more time now in the last couple of years educating our staff, including our care coordinators, on what is HCC scoring, hierarchical condition coding. Because this tells Medicare how sick our patients are. And so when you're talking to your providers and you're thinking about things that you can help them with, coding accuracy is really important. If you see that patient, for example, who has neuropathy, and you help them do a foot exam, and they have no pulses in their feet, and the provider, and their A1C is 9.5, and the provider is diagnosing them with diabetes uncomplicated, educate them. Because that really is a misnomer, it's a mistake, and it hurts your group in the long run in the sense that Medicare says, hey, listen, they're taking care of really healthy people. Well, what Medicare does is, and this happens for the hospital side and for the outpatient side, they take what's the expected and what's the actual. And what you ultimately want to do is show Medicare that you're doing a good job by taking care of patients, meaning the expected, and what happens is better than what they expect. And so when you code someone as a high-risk patient because you're accurately coding them and their cost is a little lower, that tells Medicare you're doing a good job. On the other hand, if you have all these uncomplicated diabetic patients who have foot ulcers and are getting bypasses and surgeries, you know, their cost on the other side is going to be a lot higher than what Medicare thinks they should be. And you get punished for that. And when I say punished, it doesn't really mean it hurts you today, but it hurts your organization in the long run. And so we talk about this risk stratification model. But this is one thing that you can take back to your providers because it's not complicated, and we'd be happy to provide resources to anyone who wants to see some of the tools we use to provide education to our providers. And here's a good example of this. This is basically how the health plans get paid, and this is just a real general example. But you can see that for someone who has uncomplicated diabetes and has chronic kidney disease, and we code those two, they get paid $434 a month. Now that's accurate, but it's not accurate, but it's in the general ballpark. If you, on the other hand, code them as diabetes with renal complications and CVD, that payment changes. So that combination code makes a difference. Well, there's a whole bunch of these combination codes. And without knowing this information, where would you start? So again, another risk stratification process. If you are And here's another example. Again, you can see the big differences in some of the payments. Well, when you're in a risk-sharing model, which a lot of us are or will be in, you definitely want to know that that difference is money that potentially goes into your organization's pocket and uses to motivate and to maybe even compensate your providers. I'm not going to talk too much about MIPS, but we are in that world of MIPS. If you all pay attention to this, we received our information from 2017, which affects our payment for 2019. This is the first real payment adjustment for MIPS. And all of that coding sets the expectation for Medicare of whether or not you're providing care at an appropriate cost. So that coding impacts this. It did impact for our payment for 19, but it will impact our payment for 20. And so all of these things in the long run have an impact on us. You all can learn as much about that or more than your providers because they typically don't care about this stuff. And then again, when you think about cost and quality, we want to be that low-cost, high-quality provider. Each of these dots is an organization or provider group. And when you tell Medicare that this is a sick patient population, they adjust where you stand based on your cost. So this is important stuff in terms of setting where you are compared to your peer groups. So thinking about how we manage our patient population, we really like the idea of carving out into segments. It's just much easier from the conceptual standpoint to say, okay, let's take this population of patients, rather than saying, here's a whole clinic full of people, what do I do with all this? I mean, it's overwhelming. So when you segregate into populations, it's a lot easier to make these decisions. So we look at demographic data, we can look at cost, and for some of you all, you get information from health plans. We do. You may just get information from CPC, for example. That's still information that's important. We looked at demographics, what disease states and how old are our patient populations. The 20-year-olds are different than the 80-year-olds. We know that. We should be leaving the 20-year-olds alone for the most part. And then we can look at cost. You can look at pharmacy costs. There's a lot of information we look at, and then we kind of take all that and put this in this hierarchy. And I know you all have probably seen these before. But when you think about your patient population like this, it helps you then begin to carve out the work. And the work is the hard part around this. We've really done a lot of stuff at an organizational level of how do we take that bottom part of the pyramid out of the doctor's hands and let the care coordinator do this? And how do we automate some of this? How do we do automated outreach protocols and calls? Because that healthy population, they really need a call, reminding them maybe of a wellness visit, appointment reminders, that kind of stuff. And maybe they need a phone call about a blood pressure check or a blood sugar check if they're really the young, healthy population. That at-risk population is those people who then, we know that they've got diabetes and maybe they're not managing as well. Maybe they've got some cardiovascular risk factors. Maybe we should be doing some calculations around that. That rising risk population, maybe we can do some outreach to them that's maybe a little more individual, a phone call from a person rather than an automated phone call. Maybe we just try to get them into the habit of scheduling on a regular basis. And to some degree, these are the patients that we want to be doing a lot of teaching. We need you to see us twice a year for your blood pressure, even if it's well controlled. We spent years educating people by doing automated phone calls. Now patients kind of expect that they're going to see us twice a year. I'm here for my blood pressure. Nothing. I'm doing fine. Nothing's wrong. They don't get angry and they don't say, I don't know why I have to come to this visit. And how many times have you heard that before? That education process is really important. So over time, as we've taken that kind of lower risk but not completely healthy population, we've set an expectation, and now they don't mind coming in, or at least they do it without being irritated at us. So those expectations over time add up, and people begin to understand. Because we know that some of those people who are at the moderate risk are going to jump into the high risk over time. That person who is doing fine and then has a heart attack jumps. Right? They go from the at-risk to the rising risk, or even maybe the higher risk. And so that stratification process changes. And that's one of the reasons why CPC really said, hey, listen, you need to stratify your patients on a regular basis. Because we know people move back and forth and back and forth. And I think that whole process of stratification is something you need to kind of figure out. How are we going to stratify our population on a regular basis? We've done it in an automated way, but we still stratify every day we see those patients in the office. And that's when you have to educate your providers. Okay, if something's changed, you need to get us involved. And so what's the classic change? You know, a hospitalization or an emergency room visit, right? That's the time when we say, okay, we've got to change. Let's do something about it. That person now has declared that they're moving into a different level of risk. And so what have we done because of that? You know, we kind of built this up a long time ago, and I'm just using this as an example. It's you know, what are the things that we consider risk? You know, number of medications, number of chronic conditions, you know, the age, you know, this kind of things. And this is where it was our initial process of educating the providers, because our providers said, I don't know what you mean by high risk. You mean the guy who just died of a heart attack? Yeah, we missed the boat on that. That was a little bit too far ago. So we spent a lot of time talking about this, and so if your practice is kind of new into this, you know, talk to them about what are the kind of things that you would think of that would make up high risk. And this is pretty basic if you've been doing this for a while, but you have to have a starting point. And then you've got to embed this process in your electronic medical record. So this is what it looks like in ours. We have one that we can click just as our global assessment, and then we also have the lay score that shows up in the EMR. Everyone's EMR is a little different, but it's got to be top of mind. It's got to be something that's visual for the providers. Because I may not think about risk, and I may not think about how that risk impacts my decision making at the front office when someone calls to get an appointment, or in my clinic when someone shows up because they have a runny nose and a sore throat. But gosh, you know, look at the risk is sky high. What do I need to look at? Because I'm cross-covering my partner, and I know better than to just take care of their runny nose. I'm going to look and see what other things they need to have done while they're there. And then, what do you do with the information? And so we kind of built this little toolkit around, you know, what do we expect of a provider? If someone is in a high risk, they need to be seen 3 or 4 times a year, routinely. And even if they're not having problems at that moment, that heart failure may be stable. But if they're not seen on a regular basis, you know, they drift back to those bad habits. Now they're eating, you know, the pork rinds for a snack. And like we talked about that. Why are you doing that? You know, this is the kind of stuff that we hear over and over. So it's that constant pressure. But all the different things we talk about that we add to based on risk.
Your battery is done.
Which one?
Try that.
Can you all hear me now? Yeah. So I think I'm not going to go through a lot of different things here, other than the fact that you know, you have to take that risk process and embed it into your workflows. If your front office doesn't know what risk stratification process is, they need to. Because when that person calls and says, I need to get in, and you've got a full schedule, and you've got 2 other people with runny noses that want to be seen, who gets that spot? You know, your front office should be making those decisions based on something that's relative to, not that they're the loudest or the noisiest, but they have the most need. And then, you know, like we talked a little bit about advanced care planning. You know, I mentioned that already. That's an important part of that, you know, risk stratification process. How do we embed it into our registries? Because I want to be able to take my COPD registry, if I have one, or my heart failure registry, and then pick out those patients who are the highest risk. There's tools to do all of these things, and you just have to learn how to manage those databases. And then, you know, we talked a little bit about how many high-risk patients do we have with COPD, and is there enough of those people that we could actually do a specialty clinic for our COPD patients? We diced through that registry, and we figured out how many patients we had, and we said, listen, we need to invest some money in a COPD clinic, and we did, and now we have a up and running COPD clinic because we've got such a need. We convinced our leadership to do that because we had data to support it. Our transition to care workflow in the hospital is the other one. You know, we really had to work with our leadership at our hospital, and if you're part of a healthcare system, you should be taking these tools and going back to them and saying, listen, we can help you if you want us to, by building some of these workflows around high-risk patient management, and that transition to care is a big one. You know, we do transition to care calls on all of our patients, and you all probably do too. We do it on our emergency room patients because our emergency room patients are high risk too. and talk about a patient satisfaction tool. When they get those phone calls from our office and say, gosh, I didn't even know you knew I was in the hospital, and now you've got someone calling me, that drives satisfaction like crazy. We look at our overall costs. We've driven down penalties for readmissions in the hospitals, and no one in the hospital is complaining to us because we've saved them some money. So it's a nice tool to be able to say, let me show you the value we're creating for you.
Theresa VonFelt. I work at Utica Park Clinic Central, which is right up by Hillcrest, across the street, tiny corner, L1. We have a fairly large clinic, all internal med. We have 10 providers, and there's right now 2.5 of us care coordinators working there right now. We do a lot of our care coordination. We use some of the charts that Dr. Geller showed you, but we also use our eyes and look at the patients, what's going on with them, where have they been, how often are they in the hospital. We have 4 levels of care management. We've got the complex. Did I turn that? I don't know. I didn't. We've got the complex care, which is the very high risk. Case management, which would be high risk. Disease management, which would be moderate risk. And then preventative health. So preventative health would be the very low risk, the ones that we don't see very often. Care managers, whoops. Am I going backwards? Okay. Care managers use the risk stratification to help determine who needs care management and how much care do they need. Or is it somebody we're going to see maybe once for education, or is it somebody we're going to be seeing maybe 2 or 3 times a week? And that varies from patient to patient, but let's look at each category. The low risk. These are the ones that we rarely see. Docs may see them and their weight might not be where it needs to be, or maybe their A1C might start looking like it's going to be a problem. So they'll call on us and ask us if we could do a little bit of education to try to get them on track, kind of prevent anything from going further. Let's keep them from becoming diabetic. Let's keep them from becoming overweight. And we'll probably see them once, and that would be it. The patients are good, they're ready to move on. Then we'll go on to the moderate risk, or episodic care. This would be more of a newly diagnosed hypertension, newly diagnosed diabetes, CHF, COPD. These, again, we may only see once because we're going to educate them, maybe show them how to use a glucometer, talk to them about weights. Why do they need to be weighing themselves daily? When they need to call in to the office to let us know what their weights are, if they're gaining or losing weight, or if their blood sugars are too high, and what are they going to do for those? So on our moderate risk, those are episodic cares. We may talk, like I said, once. We may do weekly or monthly for a while, just to make sure that they're on track and aren't sliding up or down in either direction. Then we'll move on to the high risk. High risk or longitudinal care. These are the ones that I see in my office the most. They need the most attention. They're maybe diabetic and their A1Cs are just way out of control. So we get them on a schedule. They'll be calling me, or I may be calling them every week. What are your blood sugars this week? Do we need to be adjusting any of your medications? And then when we do this, the doc and I are always talking to each other, maybe in person, maybe in basket, email, however we need to keep each other informed of what we do. If a patient comes in for a primary care visit, typically most of my patients will come see me after they see the doc, but some of them don't. So we'll keep track with the doctor, and I will keep track of what we're doing with each other. If I'm seeing them I'll send the doc a little message saying, okay, I talked to them today, this is what's going on. So it's just information, keeping them informed. And that's a big thing, is communication. Make sure you always keep communication open with the provider and yourself and the patient. One of the big things for your high-risk longitudinal care patients is your CHF and COPD. We want to keep them out of the hospital the best possible way. So we want to make sure that they understand what symptoms are, what those symptoms may be causing. Please call me. You know, a lot of times we can do things to help the patient without them having to go to the ER. We may have to get them into the clinic that day. We'll get them in. If maybe as the care coordinator, the doc's really swamped that day, at least get them in to see you. Listen to them, see what's going on with them. Go to the doc. Hey, brought this person in. I don't want him to go to the ER. This is what's going on. Doc may be able to tell you what you can do. But get eyes on that patient. Again, we're talking about the eyes. Seeing the patient, seeing what's going on. And we're all busy. Care coordinators along with the doctors. But our main goal is keeping these patients out of the hospital, because we all know the more they go in the hospital, sometimes the sicker they get. So we want to keep them home in their own germs, in their own territory. So, thanks. And I have patients that do call me. Teresa, I don't know what to do. I can't breathe. I'm short of breath. Just talking to them on the phone will help bring that anxiety down, and they're able to start breathing and doing okay again. So just being open and in contact with your patients. Some of the examples of the care management for the high risk would be medication adjustments. When you have a diabetic and you're working with a newly diagnosed diabetic, there's no way possible anybody can know how much insulin a newly diagnosed diabetic needs to start on that's going to get their blood sugars perfect. Well, that's kind of our job. The docs will make a prescription, we'll give them a prescription, and then give us parameters. If they're between a certain numbers, let's increase it by 2 or 3 units every 3 to 5 days until we get it at a certain thing. Well, every time we talk to the patients, then we send up, okay, we didn't do anything this week, these were their numbers, or I increased it this week because their numbers are still really high and we'll contact them again next week. So we do a lot of the medication adjustments, but we also do it under the doctor's, can't think of the word I want. Yeah, we don't do it, we're not doctors, but the doctors give us the parameters for us to be able to do that. We also watch the daily weights of the CHF patients. If they're gaining 2 or 3 pounds overnight, we want to make sure that we know it, and we want to be able to do something about it. Because we know weight gain on patients, especially overnight, that's fluid. We need to get that off of them. The COPD patients, blood pressures for the hypertension, we just want to keep track of the patient, and we want to do the big picture. Not just what's your blood pressure, but what's your blood pressure and how are you feeling? Have you taken your meds today? Have you weighed yourself? What's your diet? So it's different things. We want to talk to the patient, and we want to do the whole holistic treatment, everything around that, the big picture. Then we get to the very high. Now these patients, we will see some of these patients because they're in the hospital, they come home from the hospital, they're in and out a lot. Well, we do talk to them as care managers, but we do more with the families as a care manager when it comes to the very high-risk patients. The families are just as important as the patient because typically they're the caregiver now. So patient comes home from the hospital, even if they're on hospice, the family still needs somebody. They still need to know, are they doing okay? Do they need advice on something? So they'll call us, and we're still there for them. As for the patient with the very high risk, we will typically bring in our high risk, it's not the word I'm supposed to be using, but our complex high risk care manager, and she'll get her team together. And we get together with different people, and she'll explain a lot more on that. And talk about what we can do as a team for the patient. What does the patient need? Can they do it at home? Do we need to look for resources other places? Also, some of the resources that we use. At Utica Park Clinic, we are lucky to have social workers, we have educated, certified diabetic educators, we have social services, and then we also have the complex high-risk care team. So we're lucky to where we have a lot of resources. Okay. We're never alone. No matter how big or small your clinic is, you are never alone. One of the hard parts of my job when I first started 2 years ago was I get to the floor, and I'm all excited. I went through 3 or 4 months worth of orientation because I had never done this before. I was working in corrections before I came here, so I was working in prison. So I come here and I'm like, I have no clue what I'm doing. So I get to the clinic, I'm all excited, and I have 2 providers and a few MAs that are like, what do you want? Okay? I had a provider basically tell me not to do anything with their patient. And it's like, okay, I have a job to do. I'm a registered nurse, I'm a care coordinator. Kind of educated her on what my job was supposed to be. Believe me, it took a while. But when they say actions speak louder than words, it is so true in this job. You can tell the providers all you want, and you can tell the MAs all you want, but you basically are going into their territory. So you're a stranger coming in, things that are going through their mind is great. Now what do we have to do? What's she going to make us do? When they realize the changes that you can make with their patients, it's amazing, because now I can't keep that provider out of my office. So he has my cell phone and my office phone, and he uses it, which I'm happy about. And same with the MAs. You know, they're very welcoming now because they realize we are working as a team. It takes more than one person to make changes in a patient's life. And that's what I tell the patient also when they come in. I'm not going to tell you what to do. This is your life and your health, but we'll work as a team to get it to where you need to be.
Called the high-risk care manager for Utica Park Population Health. I've only been in Utica Park for a year, but I've been within the system for 13. I think the word or the title high-risk care manager is a little deceiving because really I'm more of a facilitator than a manager. But let me just kind of define what I found a good definition for care management is, or high-risk care management is. And that is high-risk or complex care management is for the patient with a medical condition and a complex social situation that affects medical management of that member's care and requires excessive use of resources. I think that's pretty good. I think that's a pretty good definition. This is the slide that Teresa showed you, and she talked about all the different areas of low, moderate, high risk, and she kind of touched on the very high risk, but she didn't go into great detail. But she did give you examples of patients that might be in that category. We're going to talk more about that group. Although it seems like most of our patients might fit there, actually it's only about 5 to 10%. And that is definitely variable depending on many different factors for your clinic. For instance, your number of patients, the acuity of those patients, the setting. You know, maybe rural setting, you may have less access to care. So there could definitely be more high-risk patients there, or very high-risk patients, really. Let's see. As Dr. Gallis talked about, and I won't go into too much detail with those, we do have risk tools, risk assessment tools that we use. The ones I have listed here are ones that are part of our system that we use. And generally, those are embedded in your electronic medical records, but you can also get these forms online if you don't have that system or these in a system like that, and actually calculate the scores yourself. We also identify the patients through referrals from providers. That can be the primary care, it could be a specialist, it could be the mid-level provider. Through transition of care nurses, we have those in our main hospital, and they actually work with our clinics, and they often have great knowledge on a patient's condition and their social dynamics. So they're great resources. The clinic care coordinator will usually identify a patient, and when they get to the point where they say, I don't know what else to do, that's a pretty good indicator that maybe we need to step up their management into this category. And then we do have payers that run reports, and they send us utilization reports to tell us which patients are costing the most money, and often those are the patients we're looking at too. But like Dr. Gala said, I love the eye. The main source of how you identify a patient is reading the chart, looking at the patient. The data can tell you part of the story, but the rest of the story has to come from what you look at. Okay, so what does the highest risk patient look like? Okay, these are some of the characteristics you're going to see. Maybe you'll see more, maybe you won't see this many, but usually they have an increased emergency room and inpatient admission risk, or admission numbers. They're going to the emergency room for things that they really could come to the office for. Sometimes they go without even calling the office to see if they can get an appointment. They're admitted, they go home, they're readmitted before they even get in for their TCM visit. Maybe they had complications, or they just got home and they didn't have what they needed to take care of themselves, and they got worse again. Often they have psychosocial or mental health barriers. Maybe they live alone, they have nobody to take care of them, or maybe they have a caregiver who's just stressed and, things just aren't going well. Maybe they have behavioral health issues that could include mental health diagnoses, substance abuse, depression. Maybe they just don't have motivation. They may have financial issues like homelessness, housing problems, transportation problems, medication costs. Maybe they can't afford the medication the doctor gave them, so when they get home, they just don't fill the prescription. Maybe they don't have the food that they need to stay healthy. And then again, in certain areas, there's a limited access. They could have, if they live in a rural area, maybe they don't have enough support from agencies, community agencies. And also they may have the advanced, or usually they will have, the advanced or end-stage diseases. They may have a worsening of their current disease, COPD, CHF, Alzheimer's, or maybe they have a new diagnosis that is, I see a lot of patients who are suddenly diagnosed with cancer. They weren't expecting that at all. Functional limitations. They can be physical. Maybe they have problems with their mobility. They require DME. They're just frail, overall just frail. Or they could have cognitive impairments, like dementia or Alzheimer's. Or maybe they just don't understand their health care problems. So, what do we do with this? Well, there are several things depending on the patient population, or the patient in that population. One thing is maybe we need a palliative care referral or a hospice referral. Do you see that patient dying in the next 6 months? You know, maybe you need to talk to your provider and ask them, what do you think about this? Do you see this patient dying? Should we order a hospice evaluation? Should we bring them in and let you talk to them then about that? Maybe they need long-term residential care. Maybe that's something you need to have a conversation with the family about. They can't take care of themselves at home. They're not safe. They can't get to the grocery store, and so therefore they don't have the food they need. Maybe they can't get to the pharmacy to get their medications. Maybe they actually need long-term acute care. Perhaps they have medical needs that require 24-hour care that can't happen at home. In that situation, maybe your role is to help the family manage that, give them support, help them find services that they need. Then, what I call informal collaboration between the providers and the disciplines involved in patient's care. And this could be just a conversation you're having. Hey doc, I noticed that Miss Jones really is not doing too well at home, and I'm thinking maybe she should have gone to skilled nursing from the hospital rather than home. What do you think we should do? And then just collaborate and have a plan that you can put into place. And then we have the more formal plan for a patient. And the way we do that in our clinic is the interdisciplinary team conference. Okay, not every clinic has all the people that can be involved in this, but it only takes 2 people really to have a conference. You can always go outside of your organization and draw in other disciplines. So, who's on the team? So, in our organization, our providers are, and that can be the primary care, the specialist, even the hospitalist, the social service team. You have community resources, and you can use those. In our clinic, we have social workers, and you may not have that, but that's okay. The hospital that you're connected to probably has social workers. And then there are also agencies within our state government that you can reach out to for help. Your health plan representatives, all of the representatives from our Medicare Advantage plans and even our commercial plans have people who can help you know what services they can offer, and you can reach out to those people. Get to know who they are. That can be a challenge, but if you do get to know them, their phone call away really helps. Ancillary agencies, home health, skilled nursing, rehab centers. These are all places that your patients may transition to, and they are part of the team. When a patient is in that facility and they're going to have to be discharged and you're going to have to transition that patient back to home care, they're definitely part of the team that you need to be working with. And then there's your care management team, and this is where I say it may just be you and the provider, but that's okay. It's different for every clinic, but it can include the embedded clinic care manager and a high-risk care manager, which is what I do at our clinic, diabetes educators, transition care nurses, social service team, quality team, and then any of the above. Dr. Gallus usually sits in on these conferences. So we have the team together, what do we do? Well, we review the patient, we look at the history of the disease progression. Was it slow? Was it an acute onset? Do they have a risk of sudden death? We look at the timeline of the admits and the emergency room use. We look to see what is driving those admissions and emergency room use. We look at what's going right and what's going wrong. We identify what the current treatment plan is. Do they have the services they need at home? Are there things that we need to add? Or maybe things we just need to change? We look at their caregiver and family support. Are they alone? Are they caring for others themselves? Are they stressed? Look at the education needs for patient and for the family. Do they have special nutritional needs since this admission? Maybe there's something that's going on. Maybe their albumin and their protein are low. Maybe we need to see what we need to do about that. Well, we all know wound healing. Wounds heal better with good nutrition. Do they have social or financial barriers? Do they have transportation problems, food insecurity, self-care problems? Are they safe at home? Can they afford their medications? If they have behavioral health issues, are they taking their medications? Are they seeking treatment for that? Again, we're looking at what's going wrong and what's going right. What can we do differently or in addition to what we're already doing to decrease the risk of readmission and improve their outcomes? So after we review all of that as a team, we talked about what we can do to help. And every member of the team, someone's trying to come in, every member of the team has a role in this process. And you can see up here, of course, we don't have anybody who does recreational therapy on our team, but that's certainly an action that could be taken. Maybe the person needs something to do outside of home. Maybe they need to be able to get to a center for elderly to have some interaction. But every team member leaves the table with a piece of the puzzle that they're going to do, they're going to take care of. So we make a plan, and then together, the clinic care manager and myself, we kind of oversee that plan's initiation, and then come back a few minutes later, look at the plan, what we decided, what's been done, did it work, did it not work, do we get this person graduated out of very high risk? Of course, they're probably going to go back to high risk. Or do we need to do more? Sometimes before the process gets very far, the patient has passed, unfortunately. But we try the best we can to help those that we identify. So I came up with a few resources that you might consider within your area. The community resources, online there's a website, 211.org. If you live in Tulsa, or not live in Tulsa, but if you work in Tulsa, we have the Life Senior Services. Does anyone have the vintage guide? Yeah, it's like my Bible. We have the toolkit video that you received an email link to, and you can go back to that and listen to the social workers. Conversation about resources, home health resources. We all know that home health provides in-home skilled nursing, PT, OT, and aides. But did you know that they also can provide social workers, transitional services, palliative care, hospice, patient education? Specifically with patient education, was in a conference a couple months ago and learned that not with every patient, but if the need is there, Global Health told me they can send a diabetic educator into the home. So that's a good thing to know. And then we also have, I guess that was actually part of this too, sorry. It kind of falls in both categories, the diabetes educator, but the health plan has resources. They have the telephonic and or in-home care managers. They do what we do. Their goal and their role is to transition the patient from the hospital to home with lowering the risk of readmission. Okay? They also can send in a social worker, usually through the form of home health. That's usually how they end up doing that. Some of them have transportation benefits. Humana is one of those for certain circumstances on certain plans. They can provide food. They have programs specifically for people who are getting out of the hospital where they can send them frozen meals for a certain amount of time so they have good nutrition while they're recovering. They have pharmacists who review their medications to make sure they're not on anything that interacts, or maybe they're, maybe they're on too much pain medicine or too many medications that could increase the risk of fall. Or maybe they can help with the cost of the medication.